Thank you so much, Dr. Lou Stewart. It is an honor to be here. I just want to echo the sentiments of the women who've spoken before me today. And I will it's going to sound like we kind of rehearsed all of this because you all gave the perfect introduction for what I'm about to share. I would like to share my screen. So please let me know, Dr. Slanda, if I'm able to continue.
Yes, you are.
Okay, all right. Let me know when you are able to see my presentation.
We are.
Okay. Right. Now, okay, I had to fix it so that I could see my presentation. So this is a crisis at the crossroads. So maternal mortality and intersectionality, as we discussed a little bit earlier, is a hot button topic in social media and in the media today. I just want to provide a few points. But first, disclosures. I have no financial interest to disclose, including but not limited to monetary compensation, research grants, or product sponsorships related to the content of my presentation. And I want to also give a trigger warning because in this conversation, I will be discussing maternal death. I will be discussing fetal and neonatal death, and there will be references to slavery. So now that we've gotten those housekeeping items out of the way, our objectives are to understand the history of maternal mortality and medical advances that decrease the rates, to become familiar with the current statistics regarding maternal and neonatal mortality and the racial, ethnic, and socioeconomic breakdown, to learn the most common reasons for maternal and neonatal mortality and why these illnesses disproportionately affect Black women and babies, and to gain insight on current activism and viable solutions. So, I believe that to understand what's going on in the present, we have to take a journey through history. In my current practice, I have a lot of women who are seeking low intervention care. They want everything natural, all natural. They ask us, I don't want anything done. And to be honest, there are a lot of things that we do to women that we don't need to do, but there are some things that we do need to. And those are a constant struggle in my practice. This is evidence-based. We need to do this to make sure you're okay. Please listen to us. We're just trying to take care of you. And then the question that I always get is, well, what happened before all of these things were invented? Like what happens if I don't do it? What was there before modern medicine? So I would like to just start with what happened before modern medicine. In the 1400s through the 1800s, cephalopelvic disproportion. So cephalo means head. Pelvic, of course, refers to the mom's pelvis. Disproportion means that they didn't match up. So in layman's terms, a big head and a small pelvis. So when the baby was not able to fit through the mom's pelvis, she would continue to go into labor. So the body is very wise. It understands when pregnancy is over, it's trying to expel the contents of the uterus. And just because a baby doesn't fit, labor doesn't stop. So the labor would continue for days, it would continue for weeks, and being in labor for that long was eventually fatal to the fetus. She would retain the fetus and it would stay inside and kind of shrink, begin to mummify, and the retained products would lead to an infection. She would develop a clotting disorder and have excessive bleeding and eventually pass away from sepsis. So in order to mitigate that, the cesarean delivery was introduced. And as Feliciana mentioned before, nowadays we think about cesareans in order to save the baby. In fact, one of the most common lawsuits for OBGYNs is failure to perform a timely cesarean delivery. But when cesareans were first introduced in the mid to late 1500s, they were actually intended to save live babies from mothers who were dead or dying. The focus back then wasn't necessarily the baby. We had no idea what was going on with the baby. We didn't have all these monitors that we have now. The purpose back then was population building. So there was no real attempt to save the mother. It was just whether or not the mom's condition drove the procedure. If we thought well, we're not really going to be able to save mom. Let's see if we can at least save baby. And so they would perform this procedure, obviously in a very rudimentary way, and the women would subsequently die from blood loss or infection if they were in fact alive at the time of the procedure. So then we move to what happened in the 1800s. The most likely cause of maternal mortality then was infection. In the 1600s, forceps deliveries were invented in England, and forceps were developed when the mom had a baby that didn't survive, so the baby could be extracted from the uterus without having to cut her open and perform the cesarean delivery. As you can imagine, this was a new technology, and new technologies were reserved for those who had access to higher learning. So this was taught in institutions where there were white males, and the midwives did not have access to this sort of technology. And so this kind of began the trend of squeezing out midwifery care. Now, forceps, I don't know if anyone's ever seen forceps. They look like giant spoons. And when you imagine putting giant spoons inside of a person, you're going to create some trauma, especially when you're just learning how to use them. And this trauma would tear the vaginal wall, tear the rectus, and the way that it would heal, they would heal together and in a condition called a fistula. And fistulas were extremely embarrassing. They were disfiguring birth injuries. And so then there was increased fear of these sort of complications. But women still said, well, you know what, it's still better than dying. So if I have the choice of being out here with this midwife who doesn't have access to forceps and all these fancy interventions versus going to a hospital where I may be able to get these things, this led to centralized maternity care. This is why women started going to hospitals, because they wanted to have access to modern techniques. So this led to maternity hospitals. Then with the evolution of cesarean, as general surgery got better, obstetrics got better. Simple techniques for control of blood loss. We learned that we could tie off blood vessels, that we could burn them. And then some women were surviving cesareans, and that was amazing. Things that we're learning once again in 2020, hand washing is important. We're also learning about antiseptic techniques, so using alcohol to sterilize things. Fistula repair. Dr. Marion Sims, who was at one time regarded as the father of gynecology and now sort of seen as kind of a barbarian and an outcast and a misfit of gynecologic history, learned how to repair fistulas by operating on enslaved women, and he would operate on them over and over and over again to perfect his technique without anesthesia, because the perception then was that Black women did not feel pain. And I'm going to circle back to that later on. Anesthesia was available during this time, but it was reserved for white women who were well-to-do. And then with the invention of antibiotics, we got penicillin in 1928, and things got a lot better when we were able to mass produce it in the 1950s. So the medical community said, all right, we got it all figured out. We figured out how to save the moms. Our work is done. And you know, those little cutaways where they say, but their work wasn't done. In fact, it was just the beginning, because yeah, we still don't know how to monitor babies. So we really weren't coming out with the great outcomes for the babies. And just to clarify terms before I go on, the terms I'm going to use specific to the data that I'm going to present. Fetal refers to the baby that's still in utero. Neonatal refers to the first 28 days of life. Infant refers to 29 days to 1 year old, and then a child is greater than 365 days old. So fetal and neonatal mortality. So a historical view of how little emphasis was placed on babies is that we didn't even track fetal or neonatal mortality until the 1900s. They tracked child mortality. So basically how many children survived to the age of 5. And in 1800, the child mortality rate was 462 per thousand. 46% of children did not make it to the age of 5 in 1800. That's huge. That's astounding. But by 1900, with some of the advances that I mentioned before, we were down to 23%. That's still 1 in 4 children did not make it to the age of 5. In 1950, after we had vaccines and antibiotics introduced, we saw another drastic decrease down to 4% by the age of 5. Still a high number, but just to kind of fast forward to 2020, we're now at 7 per thousand. But again, I just wanted to compare apples to apples. This is talking about child mortality rates. I do want to emphasize that most of that 7 per thousand occurs in the first year of life. So the factors that contributed to this in 1900 were pneumonia, influenza, tuberculosis, infectious causes. What's contributing now, though, preterm delivery, birth defects. So birth defects may have something to do with chromosomal abnormalities or some sort of exposure to medication or environmental factor for mom. Accidents, sudden infant death syndrome, and pregnancy complications. So today we're kind of going to highlight the first and the last one. So preterm delivery and pregnancy complications. And what I'd like to show is this graph, and this is specifically discussing infants. So these, again, babies 28 days to 1 year. So what you can see here is just kind of the horseshoe effect of when things are really bad, and then how things kind of get better, and then how things sort of increase. So socioeconomic factors we know affect the girls who are 15 to 19. A lot of them are in denial. Then they're hiding their pregnancy from their parents. This may delay care. And we know that delayed prenatal care, decreased amount of prenatal care is a risk factor for preterm delivery. From 21 to 24, from 20 to 24, they might have no job or a low paying job with or without access to insurance. They may not even have a doctor already established. And so that may lead to another delay in prenatal care. I know myself personally from 20 to 24, I was kind of a mess. I didn't have a doctor. I wasn't seeing anybody. I didn't have any money. I was a student, a broke student. I was a medical student, but this was me without a doctor, and I wasn't prepared for a pregnancy from 20 to 24, and most women aren't. From 25 to 29, they sort of have improved access. Maybe your job is a little bit better. You've gotten, some promotions. There's more awareness about the need to have a regular doctor and start getting regular checkups. And then there's that sweet spot at right about 30 to 34, where you're in a good socioeconomic state personally, but you're also not so old that your chronic health conditions increase your risk of chromosomal abnormalities. 35 to 39, you start to see a higher incidence of the genetic issues that lead to neonatal death. And then 40 plus, we have just the combination of pregnancy complications that cause preterm delivery due to mom's health history and the genetic conditions that are due to mom's age. So we see that the stratification of the reasons that babies don't make it by the age of the mother. But what is killing the mothers? Two things: high blood pressure and excessive bleeding, excessive blood loss. And Feliciana mentioned both of these things in her talk earlier. And so I just want to kind of breeze through. I'm just putting this slide up for information. I'm not going to go in depth on these definitions because the technicalities aren't as important. But the take-home message is that high blood pressure in pregnancy, which can happen anytime from 20 weeks until 6 weeks after the baby is here, but most commonly happens between 34 weeks to 2 weeks after birth. It can shut the body down. So it can affect the mom's kidneys, her brain, her liver, and it can cause excessive bleeding. So who gets this hypertension of pregnancy, this condition called preeclampsia? So moms who have high blood pressure prior to pregnancy, moms who have pre-existing conditions that affect the kidney, so like your lupus, your diabetes, moms who have a body mass index over 30, moms who are under 20, and moms who are over 40. So just kind of going back to that horseshoe, table that we saw before, the bad outcomes happen with women who are more susceptible to this disease. Anyone who's carrying more than one baby at a time. First-time moms are more susceptible, or first time with a new partner. And then African American. So all of the rest of these things we were kind of able to explain, but then we have this random independent risk factor of just being African American. So why that? And that kind of, you'll kind of see that. I love medical history, but I'm going to insert another piece just regarding the history of medical science. Because hypertension dates back to the Middle Passage and hypertension in African Americans. This is an illustration of the boats that were used to transport slaves from West Africa to the now US, to North America. And they were packed in and they were fed once a day, possibly given water. And so they could possibly starve to death, but being dehydrated is a faster killer. And in the body, water follows salt, so electrolytes. So the ability to maintain your salt and electrolytes yielded the ability to store water within your body and maintain your blood pressure, which maintains perfusion to your organs. So they were able to avoid dehydration and survive the journey of the Middle Passage. So those Africans who had the genetic mutation of the ability to retain those electrolytes and retain salt are the ancestors of the African Americans who are here today. And in modern times, the American diet is full of salt, so much salt, even more so for women of lower socioeconomic status who don't have access to better foods. So these factors combined with our proclivity to retain salt overshoots our need for just maintaining blood pressure. That was a genetic adaptation. Now we don't need that adaptation to maintain blood pressure. We take in a little bit of salt, our body retains it, and then we're retaining fluid, we have high blood pressure. So the dangers of preeclampsia, the dangers of high blood pressure in pregnancy. These blood pressures can get really high. In this population who's already very sensitive to high blood pressure, we introduce these pregnancy hormones that constrict the blood vessels even tighter, and you can get strokes due to these severely elevated blood pressures. These strokes can lead to fluid going out into the brain and cause seizures that affect brain function permanently. Women can get abnormal bleeding and blood clotting. The constricted blood vessels can compromise the supply to the baby, which leads to a low birth weight baby in the best case, or a stillbirth in our worst case. And if these things are picked up, there's a need for premature delivery, possibly to save mom's life, possibly to save baby's life. And if the baby is extremely premature, then that's an increased risk for neonatal death. And then there's also the risk due to the earlier factors, the stroke and seizures and bleeding for maternal death. So just another table that I wanted to share. So it should come no surprise given this historical context and current socioeconomic constraints. Black women were 60% more likely than white women to develop preeclampsia, 50% more likely than Hispanic women, and as you can see, more than 100% more likely than Asian or Pacific Islanders to develop preeclampsia. And this, and the chart that correlates to this one is infant mortality. So the writing is kind of small on this, but the top and the bottom data represent preterm delivery and low birth weight and maternal complications here at the bottom that lead to preterm delivery and low birth weight. And the green lines are the rates at which Black women experience these in comparison to the light blue Hispanic women and dark blue white women. And so you can just see that disorders related to short gestation, meaning preterm delivery and low birth weight, are just off the charts for African American women. So just kind of giving some context about how often we're talking about these things, because I mentioned hypertension and I mentioned excessive blood loss. So for high blood pressure, this chart ends in 2014, but extrapolating to 2020, we're right now, 1,000 out of every 10,000 delivery hospitalizations is complicated by high blood pressure. So that's 10%. So at least everyone here probably knows someone who experienced high blood pressure in pregnancy. And if you haven't met anyone yet, hi, it's nice to meet you. I had 3 pregnancies that were complicated by extremely high blood pressures after they were over. And I have amazing, beautiful children who tried to kill me. I always say right after they were born. But fortunately, I was able to go to the emergency room and seek care and recognize the pattern in my second and third pregnancies. So this, in comparison to postpartum hemorrhage, this is another one that we hear about a lot. But even though excessive blood loss is the second factor in maternal mortality, the numbers are nowhere near hypertension. This chart, though, specifically addresses the extreme cases. Most cases of excessive blood loss don't require blood transfusions, maybe 0.5%, and then another 0.3% require operative procedures like a DNC, like scraping out the excess placenta that's left behind, or a hysterectomy to stop the bleeding. But these numbers, as you can see, just are not quite as high as high blood pressure. So just kind of a brief definition of what excessive blood loss is. So first of all, the body is very wise. It gets ready for delivery by increasing the mom's blood volume during pregnancy by about 50%. So by definition, by medical definition, a hemorrhage or excessive blood loss is called when in a vaginal delivery when the mom loses about ½ liter of blood. So that's about 10% of her blood volume at that time. In a C-section, it's not called a hemorrhage until she loses about 20% of her blood volume. So we expect for women to lose more blood already in a cesarean delivery. And for women who are going into a pregnancy with poor nutritional status, they're coming in anemic with already low blood counts, they don't have the reserve for losing 20% of their blood volume. So risk factors for excessive blood loss are high blood pressure in pregnancy, having a large uterus if you're carrying a baby that's greater than 9 pounds, or carrying twins or higher babies. And this is why when we confirm twins at the beginning of pregnancy, the parents celebrate and cheer because twins are always just so cute, and the obstetricians just kind of groan and grab our faces because twins are usually trouble ahead at some point. But moms having their 5th baby or higher are at increased risk for blood loss. Moms who are delivering preterm, moms who have their labor induced. So we always try to tell moms, if you don't need to be induced for a medical reason, don't, because you're increasing your risk for blood loss. And then, as I mentioned, cesarean delivery is another. And so just to kind of bring that back, to tie that back in, to create the perfect storm for the dangers to the mom and the baby, just the top part of this chart is what we're looking at. Of women who are diagnosed with preeclampsia, 54% of them will deliver by cesarean. So you already have this issue of high blood loss, and you add to it the additional risk factor of cesarean compared to the 30% average across the board of how many women get cesarean, which I still think is too high, but that's a conversation for another day. And so this is the statistic that has everyone all up in arms. It set everyone on fire. It was released by the National Center for Health Statistics, that Black women were 2.5 to 3 times more likely to experience a fatal event in childbirth than white and Hispanic women. And 37 per 100,000 is still 0.037%, which is a vast improvement over the 20% mortality rate of the 1800s. But we don't have a good reason for the discordant numbers. Like if maternal mortality is happening, it should be happening at the same rate in all populations. And so although we've been talking about socioeconomic status as a risk factor, this risk spans across the channel. Black women with a college degree are still 5 times as likely to suffer catastrophic event in pregnancy than their white counterparts. And I have pictures here of 3 beautiful, educated, intelligent women who we've lost to complications of childbirth just recently. Lieutenant Commander Irving was a Johns Hopkins graduate. She had 2 master's degrees and a doctorate. Kira Johnson was an entrepreneur who spoke 5 languages. And Dr. Wallace was a pediatric resident. She was a physician who was getting ready to enter practice, who we lost just last month. And if this is happening to those of us with whom the majority can socioeconomically identify, how much more is it happening to our underrepresented moms with no one to advocate for them? And to paraphrase Ayanna Van Zandt, in order to address a thing, we must call the thing a thing. If a well-controlled diabetic gets pneumonia and she gets admitted to the ICU, infection makes her blood sugars uncontrollable. She goes into a diabetic coma and she dies. She doesn't die from having diabetes. She dies from pneumonia. If a Black woman gets preeclampsia, goes to the hospital, and does not receive the same blood pressure lowering treatment as her white counterpart. She goes home and has a stroke. She does not die from hypertension. She dies from systemic racism. Recognizing the difference in those two definitions is important in making sense of these numbers, because the trickle down is this set of data. Our babies are dying at higher rates right along with their mothers. The media response to this has been phenomenal. It's still not enough, but it's a good start. The Listen to Black Women campaign encourages healthcare institutions and facilities to call out implicit biases in healthcare. It encourages women to use the power of legislation to advocate for consequences regarding gaps in healthcare. Nothing's going to change until this affects the reimbursement of hospitals. If they're not hit in the pockets, there's no real incentive to improve care. And it seeks the implementation of expanded team members beyond the traditional physician, midwife, nurse combination. It's just not getting the job done. We need more team members. Some of the suggested measures, I advocate for the midwifery model of care because it's based on the concept that pregnancy and birth are normal physiologic events. I tell my patients, this is the coolest thing your body is ever going to do. This is amazing. This is awesome. I don't want women to go into their pregnancies with the fear and with the belief that this is the closest that they're going to get to death. Pregnancy is supposed to be normal. Pregnancy is supposed to be beautiful. But women require individualized education on their own personal risk factors, and they need to establish prenatal care early and have it consistently to establish rapport. And then they need to be able to go to the institutions where the people with whom they've established rapport are delivering. They need to see familiar faces when they're in labor to feel safe. And this is a collaborative effort with the midwives integrated with physician care, because we've also heard the narrative, midwives are the solution to the crisis. By definition, midwives are the experts in normal low risk care. By definition, if someone dies from a complication of pregnancy, they are not normal or low risk. And so it requires collaboration with physicians who have measures in place to take an action. Doula care. Doulas are not medical professionals, but they're labor support advocates, and they advocate for patients to retain their autonomy in the setting of necessary medical interventions. So that patient who didn't understand why she was getting a C-section, if she had a doula there to just kind of stand in the gap and help to explain to her what was going on, someone who'd seen labor before and could explain it to her in her terms, she would have felt more comfortable. But paraprofessional care, I believe, is what's going to really help. This is the crucial part that's missing. Those women or men who are standing in the gap, they can visit the mothers during the crucial weeks between 34 weeks to 2 weeks postpartum. They need to be trained in signs of excessive blood loss, trained in taking blood pressures, and being able to report to an abnormal to someone who has a standardized plan in place for action. Because whatever the solution is, there is one thing that is clear. The lesson that we began to learn in the 1500s is that our best chance at saving our babies is saving our moms. And I want to thank you again, Dr. Lou Stewart, for giving me the opportunity to share with you all this morning. And I'm happy to participate in discussion at this point.
Thank you, Dr. Adams, for such a powerful presentation. We are now going to be joined by Dr. Karen Ali Herndon, who is going to serve as our chat monitor for this session. So if you have any questions, please place them in the chat below, or Dr. Ali Herndon will also be able to take them if you want to unmute your microphone. Dr. Karen Ali Herndon is an assistant professor in the College of Education at Mercer University. She's a 2019 PhD graduate from UCF in elementary education with an emphasis on supporting high needs populations. Her timely research focuses on how poverty affects cognitive development, executive function, and self-regulation as predictors of school readiness and achievement, and instructional strategies, including play, to reduce achievement gaps. Dr. Karen, if you would like to share some of the themes, and if you can monitor our chat if there's any questions.
Absolutely. Thank you, Dr. Slanda, and thank you, Dr. Adams. I think overwhelmingly the chat is thankful for your presentation and for the colleagues who spoke before you. The first question that we have is kind of a general question that you started to address, Dr. Adams, and it's what can we do to address these issues? And then more specifically, we have a Black religious leader in the audience who's asking, what can religious and other community leaders do to help with standing in the gap?
Yes, so I think as you mentioned, what I think people just need to know what are the risk factors, like what is actually killing women, because we hear stories of, well, she went to the emergency room and she had pain and they didn't pay attention, and then she went home and she died. And if they had only listened to her about her pain, but that's like 9 times out of 10 that's not what happened. She went to the emergency room, she complained of pain, they completely and thoroughly worked up her pain and realized that her pain was absolutely nothing. But what happened was, when she checked in at triage, her blood pressure was 160 over 100. And they ignored that and paid complete attention to what happened to her pain. And they sent her home with the elevated blood pressure. And that's what actually led to her death. We don't get the whole story. All we get is the patient's perception or the third party view of what actually happened. And it's, oh, you're not listening to us. We heard what you said, but we didn't pay attention to our own data. We didn't have a protocol in place that every woman who comes in with an elevated blood pressure, you see a number over 140, you see a number over 90, that person needs to be in conversation. That person should not leave the emergency room without a consultation with an OBGYN.
Thank you, Dr. Adams. We have another question specifically for you. The statistics you mentioned offer data regarding African-American women. And the question is, does the data offer any distinction for risk factors between African-American women versus other Black women, for example, Caribbean-American women?
So it actually combines everyone. So they are examining the Afro-Caribbean diaspora. So anyone who is of original African descent. So as I mentioned, this is anyone who is sort of a transplant from the West African origin. So the Caribbean population is included in those statistics.
Thank you, Dr. Adams. I want to revisit the question from our faith leaders in the audience as they have a particular avenue into their communities. Do you have any specific suggestions or other presenters for how faith leaders can be involved in supporting this work?
So if moms are identified, so we have at our church the ability to provide certain medical supplies, to congregation during if they come to church and they have some sort of attack, we can check their blood sugars, check their blood pressures. If the church purchases a couple of blood pressure cuffs, identify pregnant members in the congregation, loan the cuffs out to them so that they can monitor blood pressures at home. This is one of the big things that I say to moms, like as soon as an African-American mom starts with me, get a blood pressure cuff. Why? I never had a blood pressure before. Nope, but you're African-American. Get a blood pressure cuff, because eventually this may become an issue for you. So church is just in a real tangible thing that you can do is have some sort of program where pregnant moms in the church can borrow your blood pressure cuff for as long as they're pregnant. And when they're not pregnant anymore, bring it back and you can give it to somebody else. Have someone at the church who can train them, or have an electronic cuff where they can take it and give them the numbers for which they need to call someone and seek help.
Thank you. That is such a practical and easily achievable suggestion. We have a question from Pamela Meadows. She's a healthcare professional and a mother who just gave birth with a complicated pregnancy. And she's asking you, Dr. Adams, how does a regular patient start this conversation with their OBGYN or healthcare professionals, minority or not? And what questions should they be specifically asking? This is often a difficult conversation to have.
Yes. So interestingly, I get I get this call a lot now, and I'm excited about it because women call the office now, and they specifically ask my front office staff, "Do you listen to Black women?" And I love that. Now, it's kind of funny because they probably hadn't seen my face or my partner's face, because my partner is also an African American woman, and my staff always says, "Well, yes, we do, but do you? Like, are you going to listen to the doctor when she tells you what to do?" But I would ask them whether they have in place standards and protocols regarding culturally competent care. My nurse practitioner midwives are not African American, but we have had this conversation multiple times. And when they go into a room, my Black patients are surprised to hear coming out of the white faces of my midwives, "I'm asking you this because you are Black. I know you're under different stressors in these politically charged times because you are Black. You are at higher risk for these complications because you're Black." And no one says that out loud to Black patients, and it's shocking to them, and we're kind of taken aback, and they don't know how to respond to it. But my patients are beginning to realize that this is a safe place that they can come, that we recognize that things are different, that they are treated differently, and we are going to be the people who advocate for them.
Thank you. I think it's so important as patients to advocate for your own care. I realize that that comes from a place of privilege. Feliciana's story, obviously, the patient she was describing didn't have access to options to be able to say, well, if you won't listen to me and take me seriously and be culturally competent, I will go elsewhere. So that's a systemic issue. Dr. Lou Stewart is posing the question for the general order: should culturally competent, medical care be included in the medical school curriculum at various levels for physician or other healthcare providers?
That's for Dr. Adams.
Sure. So interestingly, I trained at Meharry, as I mentioned before. Meharry is an historically Black college. And we actually had some cultural competence. We learned a little bit about how patients come into the emergency room. Our patients we had a large Latin American population, and we had to learn that they were going to come into the emergency room all together, and they all wanted to come to the back together because they didn't like to separate it as a family. And we learned that our patients who were Asian would, after surgery, want to drink something hot because surgery was considered a cold disease, and so the yin and yang. And so we learned different things about our patients culturally, and it was interesting because that was at a historically Black college. And I'm not sure that at predominant colleges that they're also being taught to consider these sort of things. Anyone who's in healthcare is familiar with the fact that the Ashkenazi Jewish population has higher instances of genetic disorders. And so there are certain genetic testing panels that you would offer to someone just because they're Ashkenazi Jewish. And you don't think of that as discriminatory or racist or anything like that. But we can't apply the same logic to if someone is African American, that there are certain different factors that we should be considering, and different tests that we should be offering, and different monitoring that should be in place. So to answer your question, absolutely, it should be on everyone's radar that there are differences that we're all different, and not trying to see us as a homogenized population, but as separate populations with different needs.
Thank you. I think you're touching on also just kind of discrimination against women in medicine and medical studies and in medical care. So I think this advocacy is important. We have another participant who mentioned feeling somewhat reluctant to offend medical staff. And she had a wonderful doula who encouraged her to stand up for herself and advocate for herself and suggest we need more minority doulas. So I think that this is a great time to kind of wrap up our discussion. If you have remaining questions, please do put them in the chat. We will try to get them to the appropriate people so that they can be answered. I think, this third Wednesday meeting is a great example of various community members from a whole variety of different educational and professional areas of focus coming together to look at community concerns and try to tap into our various resources and assets to be able to help solve some persistent and pervasive problems. And we had one person do mention cultural humility as opposed to competence. It's a nice nuanced turn of phrase, but I think we all have continued learning to do.
I like it.